And good morning. It is now March 21, 2024. I'm Dr. Deuk here at Deuk Spine Institute with my team. We're getting ready to perform the Deuk laser disc repair for a cervical disc herniation, C3-4. Our patient has a large herniation with spinal cord compression and myelopathy. He's actually losing function in his leg intermittently as a result of the spinal cord being pinched. He has a large herniation posterior at C3-4 compressing the cord. He wanted the laser surgery. He did not want a fusion. I don't blame him. I wouldn't either. So we're going to get started. He's intubated, asleep, relaxed. We're going to use the x-ray machine to find C3-4, and we're going to repair it. Now, he is from Utah. We actually fixed his back the other day. So he's back from his back surgery to get his neck fixed. All right. So the first thing I'm doing is palpating his spine. There's 2, 3, 4. Give me an AP. I'm using the lateral x-ray view to find the C3-4 disc on the lateral view. Then I'm using an AP view to make sure I'm in the middle. Yes, we're in the center. So now that I know we're in the center and we're at the right disc, I'm going to advance my needle into C3-4. I'm literally pushing the esophagus and the endotracheal tube, everything, moving it over. Shot? All right, AP. You can see the front of the spine there. I want to make sure I'm in the middle. Quick shot. All right, we are a little bit off to his right side, so I'm going to come back, and I'm going to slide back towards me and shot. That's better. So let's go back to a lateral view. That's dead center. You guys see the tip of the needle there?
Yes, we do.
Shot. All right, so it's perfect. I'm right in at C3-4. I'm going to enter the disc with my needle. Shot. Okay. I'm right going through the annulus, through the front. Anterior annulus. Now, people ask me, aren't you putting a hole in the disc? No, we're not. We are no more than putting a pin through your lapel, a little pin, like a boutonniere or something. You know, that pin does not cut your clothing, it spreads the fibers of your clothing. And something that most people don't understand is that all the tissues in your body are fibrous, like not all of them, but most of them. And they have connective tissue. Shot? All right, there's the tear. It is huge. Show us the tear, Jordan. Get a quick AP for our audience. You can see the dye leaking out the back of the disc around the herniation. And let's do a quick AP. All right, look at that. So you can see the dye leaking out on both sides, out the foramen, and it's going around the nerve right there. Okay, we're going to fix both sides. Let's go back to a lateral view. So far we've placed the needle into the disc that we're trying to fix. Everybody agree? Yes, sir. That is number 2, 3, 4. We're supposed to fix 3, 4. Everyone agree? All right. So we're at the right level. We're in the right position. We've used x-ray to confirm it. Deuk Spine uses only the very best equipment available. Our x-ray machines are top of the line, made by Siemens in Germany. You cannot buy a better x-ray machine, intraoperative fluoroscopic machine. In my opinion, they're the best. The incision is 4 millimeters. We've actually lost more blood from putting the numbing medicine in, the needle stick for the numbing medicine, than we did for the incision. All right, now I've got my guide wire through the needle. We're going to remove the actual needle itself. You got to hold the guide wire steady. You do not want it going in or out. If it goes in, you have a problem. If it goes out, you have a problem. So you got to hold the guide wire steady. Next, can you guys see this, Henry, this long metal pencil?
Yes, we can.
It's called a dilator. It's going to spread the tissues apart. It doesn't cut. The tip of it is not cutting. It's a spreading. Shot? All right, you see how the guide wire is at the back of the disc? Look at the herniation. You can actually see the massive herniation. Show us. It looks like a giant basketball there. Yeah. You got it. Could you see that, Henry?
Yes, we did.
All right, as I advance the dilator, I want to watch my guide wire. I don't want it going much further in. You could see shot. Keep going. Shot. Keep taking shots as I do this so you can watch it advance. Very nice. Now, I'm very happy. I feel the front of the disc. I want to know that I'm in the middle. So I'm going to check my AP view once again. AP is a front-back view. Remember, the views you're looking at are the side views. We want to look from the front. We want at least 2 views, front, back, and look at that, perfect. You can see, show us on that image there, Jordan, the temperature probe in the esophagus. It's braided, that's correct. Show us the endotracheal tube in the trachea. Perfect. So you got 2 viscous hollow structures that are being displaced, the trachea and the esophagus shut. And now that I'm right at the front of this disc, I'm going to take my guide wire out and I'm going to advance the dilator through the annulus, the anterior annulus, into the disc. We're going to go all the way back to the herniation. Now, I am passing into the tear right here. You guys see the tear? Show us the tear in front of the dilator. You guys see the giant annular tear right there, that black line? Yep.
Yes,
I'm
we do.
actually going through the tear to the back of the disc. People ask me, aren't you damaging the disc with this? No, we're not. The disc is already damaged. If the disc wasn't damaged, we wouldn't be doing surgery. So the fact that the disc has a tear and a herniation, we're using that area that's already damaged. We're going through it, so we're not creating more damage. That's why this is the perfect surgery for herniated discs, because it uses the damaged area to pass through to get to the herniation. Henry, let's show our audience how is it that herniated disc can cause so much pain in the neck? Thanks. Welcome back. Now you see how herniated disc can cause so much pain. It's all due to inflammation. See, what happens is normally there's no inflammation at the back of your disc. However, when you get a tear in the annulus and the nuclear material squeezes out into the tear, there's a piece of herniation. That's our first piece. We're going to have a lot more. When the nucleus squeezes into the annular tear, the inflammatory system, the blood vessels, which are normally not found in the center of your disc, but they're found in the outer fibers, the outer annulus, they actually can now see your nucleus and they say, wait a second, what is this stuff? It's not supposed to be here, and your body attacks the nucleus. It attacks the herniation. It thinks the herniation is something, it's not like a bacteria or a piece of wood or something that's foreign. We call it foreign to your body, foreign. Foreign means your body doesn't recognize it as itself. So your herniation is recognized as a foreign body, and your inflammatory system attacks it. The inflammatory system doesn't have a brain. It's not too smart. It's old, okay? Not that old people are not smart, but it's old, and it doesn't, it's very, what do you call it? Primitive. Did you say primitive? That's the right word. Thank you, Luis. It's primitive. It's not intelligent. I mean, it is intelligent, but it's not intelligent enough. Right. So it just attacks your nucleus, and that's where all the pain comes from. And I'm the one who discovered that fact here at Deuk Spine Institute, and I realized that's where all the pain was coming from when people had neck pain and back pain. And the reason why you can feel that pain is because there's small nerves running along the back of your disc, and they're called the sinovertebral nerve. And our new animations that we haven't gotten yet from our animator are going to have that nerve on them. Actually, no, they do have it for the lumbar. They don't have it for the cervical yet because we haven't finished cervical. There's another piece of herniation. Lots of pieces. So far I've counted 8. This one is so big it doesn't even want to come out. Now look at this herniation. This is a new herniation. I could tell because it doesn't have smooth edges. It's not calcified. It looks recent. Now he was telling me his leg is going out from him. His left leg is just giving out. The reason for that is his spinal cord is being crushed and by the herniation here in his neck. So I think that's going to go away once we decompress his spinal cord. Now he did not want a fusion. He was offered fusion by other doctors. He said no. I don't want an ACDF. ACDF stands for anterior cervical decompression or discectomy and fusion. It's really a decompressive discectomy, but when you do it as an orthopedic surgeon, they don't do a decompression, so they call it a discectomy. So anterior cervical discectomy and fusion, or if you're a neurosurgeon doing what you're supposed to do, anterior cervical decompression and fusion. All right, lots of herniation. Look at all these pieces. So I need about 8 minutes more maybe, and I'll be done. So let them know when you want them to bring the patient back for the next case. All right, let's show our audience how this surgery actually works. So far, I'm up to about 15 pieces of herniation. All right, welcome back. And we are removing pieces of herniation at C3-C4. There's been a lot. A couple of points I'd like to make before I take questions. Number one, all these pieces of herniation, like this is an old one right here. Some of the other ones were younger, but this is an older one. You see how it's golden color? That's because it's calcified. It's got calcium. So this is not fresh, this is old, okay? And that's actually in the foramen on the right side, pinching the nerve. All right, now, some of them are newer herniations, like this right here. I've stopped counting. There's too many for me to keep track of. I've counted over 20 pieces, which means this patient has had 20 herniations, at least. And there's more. So he's had however many fragments you're seeing here, that's a herniation. So when we talk about a herniated disc, we don't mean one herniation. We mean, and this, we're the first to describe this, by the way, and I haven't published it yet, but when you talk about a herniated disc, you're really talking about multiple pieces of herniation. Like here's another one. I see about 25 to 30 per disc. All right, we'll take your question.
This question comes from Georgios on YouTube.
Georgios, yeah, I just met Georgios.
Beautiful. And they asked, does the dilator enter the annulus fibrosis or in the inner annulus? The x-ray looks like it's in the inner annulus.
Inner annulus. The annulus goes through the, the dilator goes through the entire annulus from front to back. I'm not sure what his question is. Any other questions?
As of now, no current questions.
All right, so we're just using our laser to remove pieces of herniation. And again, there's lots and lots of pieces. It's not one, it's many. And there's a piece that just came out. You guys see that?
Yes,
It
we do.
literally came out from pushing on the spinal cord. Now I'm going to try to take it out. Look at the edges of it, how feathery they are. That's because that's a new herniation. It's not an old one. Remember, the old ones are more scarred up. All right. They look different. They're smoother, and they have more calcium. They have more scar tissue. I have a feeling we're going to see even more of those come out. There's the posterior ligament, posterior longitudinal ligament. You all see that?
Yes, we do.
There's the tear. That's where his herniation went out through. Right there. Damn it. Fucking thing. Little bit of bone spur. That's the foramen again. Moving back towards the center. All these pieces are blocking up my view, making it really hard for me to see. God damn it. Fuck out of there. So you're watching history, folks. This surgery you're watching, we pioneered here, I did, at Deuk Spine. There's the posterior ligament right there. You can see the herniation behind it. See that? That's a herniated disc right there. Should not be there. That's posterior ligament again. The posterior ligament is about 1/10 of a millimeter thick. That, by the way, that glass tube that you're seeing there is 1/2 millimeter, 0.5. So the posterior ligament is 1/10 of a millimeter, less than 1/10, almost 1/20th of a millimeter. Okay? And you can see all the scar tissue here from the inflammation. Body trying to get rid of this thing. Body cannot get rid of the herniation. People think herniations go away on their own. They don't. They just feel better for a little while until you do some more herniation. But this is the herniation right here. It's sitting on top of his spinal cord. This is what's causing his leg to go weak. Oh, look at this. His piece is coming out. Oh, yeah. Wow, what a view, huh, folks? Beautiful view. Oh, there's a big one. Look at how calcified that thing is. Oh, that's a big one. And again, it's trapped underneath the ligament. You see that? So I literally have to release it to get it out. Now, if I was doing an ACDF, I would be cutting that ligament with a curette, a metal curette. I use a Codman curette. It's the only curette I'll use is Codman. And they're the best. Look at how calcified that is. That's been there a while. Okay? That's not fresh. That is old. So again, this highlights how he has new herniations that are probably a few months old, and he's got old herniation that's probably 10 years old, right next to each other. So it just highlights the point that a herniated disc is not. By the way, I'm literally vaporizing single fibers of scar tissue, which is, now you're talking about 1/100th of a millimeter. That's how precise the laser is. People are always asking me, is the laser safe? Of course it's safe if in the right hands. Is an AK-47 safe? Only if it's in the right hands. You know, you give it to a 5-year-old kid, it's not safe. So Just like, you know, guns are not safe for everybody, well, neither is a laser, right? But you give a laser to Han Solo, you're good. You like that, Han Solo? I had to make sure people are awake. All right. Now I've really got 5 minutes. So if you guys want to bring our next one back, this would be a good time if Dr. Berndes is okay with that. Huh? Yeah, but are you okay if they bring him back?
Let me see how he wakes.
So you want to wait?
And then before I pull the tube.
All right, fine. Boy, that you could see where the spinal cord was getting crushed right there. Any questions?
Yes, we have a question from Gerald on Facebook.
Yes, Gerald, welcome.
They said, I had cervical C5 to C6 fusion on the right side. Not only do I now have vocal cord paralysis on the right side, but also I've had issues extending, flexing on my right arm. Been
Yeah.
going to therapy for 3 months, but I don't feel it's helping. Can that type of surgery cause that issue as well?
Yes. Yes, it can, Gerald. You've had bad surgery. I've done 1,000 ACDFs. I never had a vocal cord injury, not one. If you do the surgery the right way, you won't get a vocal cord injury. So somebody is not a very good surgeon. There's a lot of bad spine surgeons out there. People don't understand that. And I'm so sorry that people suffer like you. The complication rate for ACDF is 50%. And you clearly are in the 50% that had a complication. Okay? My point is, avoid ACDF. This is the surgery you want done. Now that you've had the ACDF, it sounds like you're having problems. I can probably help you get out of some of that pain. Okay? But I need to see your MRI. And you need to do an MRI review with me. So use our link for a free MRI review. All right, I think I'm just about done. Yeah, let me just make sure. Looks like there's a little bit more ligament here. I want to make sure there's no more herniation behind it. Okay? That's the spinal cord right there. Okay? Just so you know. I think we're good. Now, another thing people say, oh, there's a fresh herniation. You guys see how feathered it is? That thing came out like a week ago. Maybe even today. What's that movement? He's not moving, right? He's still, is he still chemically paralyzed?
No.
Okay.
I just the first one.
All right. Yeah, so I should be done very quickly. Yeah, once again, I've counted,
Probably checking the twitch.
that's probably was. I've counted about 50 herniations, at least. 50. And now we're just about done.
I didn't
Oh.
write those down 'cause you said five.
Yeah, I'm done. I mean, I'm done. I'm just doing the last few touches. Folks, one more thing I want to say that's important. We never get 100% of the herniation. Nobody can. It's impossible. Okay? So don't expect all the herniation to be gone because it's not possible to do. I'm just trying to figure out if there's still some there. You know? That's literally 1/100th of a millimeter right there. That's how precise this tool is. I don't see much more herniation. There's a little bit of scar tissue there. I'm just verifying. I don't really see. You can see where the spinal cord was being indented right here by the herniation. It's now gone. So I don't see anything more. Let me just check this last area over here. This is the foramen. I was already working on this earlier. I need this moved. Come on. There's a little piece. This is the annular debridement we talk about all the time. annular debridement. There's a little bit here in the foramen. My fiber is migrating backwards. There we go. "30 seconds. Any more questions, Henry?
Yes, actually, we have a question from Diego on LinkedIn.
Diego.
Yes, and
All right.
Diego asks, "Hey, Dr. Duke, did you get a new laser?"
Hi, Diego. We got a bunch of new lasers. We have 10 lasers now. We're the proud owners of 10 lasers. We have a fleet. And Luis and Nikki manage the lasers. And we have some help, outside help from technicians. But yeah, we have 10 lasers now. We were thinking we're going to use them over in Orlando, but Orlando is going to have to be put on hold. As I said the last time we did surgery, we don't have the funds to build Orlando. Unfortunately, this 2024 is a weird situation. All these subs want way too much money to build medical buildings, any buildings. The costs are out of control. I just found a few more pieces. That's why it's taking me a little bit longer than I expected. Now, I was saying earlier, we don't get all the herniation out. It's just not possible because there's too many pieces that are just kind of hidden off. And the main thing is you want to get them out of where they're causing problems, the ones that are symptomatic. Okay? The ones that are pinching nerves or causing inflammation. Those are the ones you want to get rid of. I'm now up to about 80 pieces of herniation. Alrighty. Well, we cleaned out that foramen good. I think we're done. I'm going to show you the size of the incision here. It's tiny. I'm going to flush out the area, see if there's any loose pieces. We do use some antibiotics in our irrigation. So, not had an infection. At one point I was using a higher concentration of the betadine and it was causing some reaction in some patients. But we kind of cut back on the concentration and haven't had any issues. All right, can you guys see the tube here?
Yes, we can.
That's a 4mm tube. Okay, 4mm. And so the incision is 4mm. All right, and there's no bleeding. We literally lost like 5 drops of blood the whole surgery. Taking the tube out, we'll show you. It's amazing. That's why these patients don't get recurrent laryngeal nerve injuries. They don't get hoarseness or trouble swallowing after surgery because we're not cutting their neck open. When you have a invasive surgery like ACDF, artificial disc, laminectomy, you're seeing a little incision on the skin. You're not seeing the whole picture. You're just seeing a small little thing. Oh, show them the incision. Okay? This is what happened. It looks like this patient came from Utah to Florida and they got bitten by a vampire with a broken tooth. Right? So only one little puncture. Hi. Scope use is a 4. It's a beautiful scope, man. That image is amazing. All right, any other questions? Type them up. I'll come answer them for you in a few minutes. Can we bring the other patient back? Go ahead, guys. Nikki, you want to help? Dr. Davis? I'll see you guys over there in a little bit. I'll come over there and answer questions.
Copy that.
I'm here with my patient who traveled from California, Northern California. He had a herniated disc at C5-6. It was a small disc bulge. He was told by the doctors in California that he should just live with the pain, give it time, and eventually he'll need a fusion. Is that right?
That is correct. I was told that within 5 years I would be needing surgery. So basically what they were saying, live with pain for 5 more years and then we'll do something about it. One of the things that I've seen a lot of the videos is testimonials, and I will always say, this doctor sounds too good to be true. And actually it is true. I appreciate you, doctor. I really think that is really nice procedure, and the staff here is really nice. They're always very friendly and kind to get you through the process, because when you get told so many times that that's your new life, it's kind of, you're always thinking, is really the way I want to live? If I'm going to live a lot of years, why wait with pain? You know, you need to do something different. And always, whenever you see videos, you're always a little sketchy and saying, maybe it's not true. Maybe this is not what it is really saying. But today, when I felt with no numbness and no pain on the neck and just going through the process, I really been blessed. I'll be flying to California today. I honestly can't say much. You know, it's a miracle. Whenever I heard the testimonials, they say you're a tool for God. It actually seems like that's the way it is. It's a miracle through you. God works through you, and it's awesome to feel better, you know?
I'm so happy for you and your lovely wife who's here with you. You can see you had a tiny little incision. You had the Deuk laser disc repair for your herniated disc. You can see we were in there with the laser, cleaning out that foramen on the right side where the nerve was being pinched. There were a lot of pieces of herniation in there. And the laser cleaned them all out, and your surgery went perfect, and here you are less than 24 hours later. Feeling good, huh?
Well,
With
yeah.
a smile on your face. That's what I like to see.
You know, it's a smile of happiness. It's a smile of joy, you know, that it is doable. And I think no one should be able to be living with pain. I was so happy to see testimonials when they used to say, well, the one regret I have is not going in earlier and living 18, 20 years with pain. For me, it's been 3 years since July of 2020. It's been miserable because I've been with pain. And I've been told by doctors, let's just take time. I did all kinds of physical therapy, acupuncture, you name it, everything that's out there, and nothing seemed to help. And today, with 1 day of getting something really that's gonna be for life, it's amazing. It's a smile of joy, you know? If you are going through this trouble, don't hesitate on sending your MRI. When I did it, I sent my MRI for free review, and my answer was, yes, you are a candidate. Here I am today, flying back with literally no pain on my neck and no numbness on my hand, which I miss that. It's awesome.
It's wonderful. Now, what is your native tongue? What is your native language?
It's Spanish.
Are you from Mexico originally?
Guadalajara, Jalisco, Mexico.
Guadalajara.
Yes.
One of my favorite songs. Can you tell them in your native tongue how you feel?
Yeah. Quisiera decirles que si están teniendo problemas con una hernia en su cuerpo, manden su MRI, es gratis y les van a dar un resultado, una verificación si ustedes son candidatos. No vivan con dolor, porque el dolor les va a causar toda la vida, y los doctores allá afuera les dicen que no hay solución, pero las soluciones existen, simplemente las tienes que buscar y creer, tener fe que tú vas a estar mejor. Si Dios te mandó a este mundo es para que vivas bien, no para que vivas con dolor. Así que te recomiendo que por favor tomes esto en serio, hagas ese paso de mandar tu MRI gratis y habla ya sea con quien tengas que hablar para que ellos te empiecen a guiar y te digan qué es el siguiente paso que tienes que tomar. Así que una recomendación con Dr. Deuk. Muchas gracias.
Muchas gracias, amigo. And Feliz Navidad.
Feliz Navidad. Gracias.
Safe travels, my friend. Thank you so much for sharing. All right, Dr. Deuk here, and we have just completed a successful Deuk laser disc repair for a herniated disc in the neck. Thanks, Henry.
No problem.
So if you want to know what's going on here, let me show you. This is your disc that we just operated on, C3-4. I'm going to put it where it belongs, right here, on the spine. Okay, can you guys see this all right?
Yes, we can.
All right. Now, if you look here at the spine, you've got bones all vertebrae, and the specific part of the bone that goes above and below the disc is called the vertebral body. Okay, it's a big flat bone, and between the vertebral bodies is the disc or a joint. Now, this patient had a damaged disc at C3-4, so C4, C3, and the part that was damaged, there was a tear in the back wall, and the jelly had pushed out. We call it a herniation. It was pushing on the yellow thing, his spinal cord. Okay, so I went through the front, and I went back to the herniation. We used a laser to remove it endoscopically, and that's what we just finished. And we call this procedure the Deuk laser disc repair. I pioneered it. It was developed here at Deuk Spine. We are not the first to do endoscopic spine surgery. That's Parvis Camden. He was an orthopedic surgeon in Pittsburgh. He was the first to do it in the lower back. The Koreans were the first to do it in the neck, and I was the first to do it thoracic. So lumbar, Dr. Camden; cervical, Dr. Sang-Ho Lee; and thoracic, Dr. Deuk Majin. But now, Deuk Spine, we are the leaders in the world at doing laser endoscopic spine surgery. We do more than anybody else. And there's a reason we do the laser. You just saw it. It's extremely precise. I was literally cutting individual fibers of connective tissue. Now, why is that important to be able to have that much control? Because you're working on top of the nerves and spinal cord. You saw the spinal cord was the indented white thing at the end. We removed the herniation, so it's not pushing on it anymore, but you can still see it's indented. It's going to take time for it to take its normal shape back, and hopefully it will. Maybe it won't. Maybe it's permanently indented. It's hard to say. About 50% of the time it goes back to normal, 50% of the time it doesn't. Point is, we got it decompressed nicely. But to do that, I used a laser, and the laser is the most precise tool in surgery, period, hands down. That precision you just witnessed for the first time with clarity using the endoscope, 1/100th of a millimeter. 1/100th of that's literally a tenth of a millimeter. Okay? We're almost at nanometer scale, which is incredible. That said, the surgery went well. He's going to do fine. By the way, this is outpatient. He's going home in an hour. There's no metal. We're not putting metal in the spine. All these doctors want to put metal in your spine because that's what pays the most money to them. I don't. I want to do what's best for the patients. So, questions?
Question, these first two come from Nicholas on Facebook.
Hi, Nicholas. Welcome.
First question asking, Doc, can you explain the difference between endoscopic microdiscectomy versus a DLDR?
Yeah, we actually, Nicholas, the question is, can you explain the difference between endoscopic microdiscectomy versus DLDR? There is no such thing as endoscopic microdiscectomy, okay? They're just throwing the word endoscopic to trap you into believing they're doing something endoscopic. True endoscopic surgery is what I do. Now, microdiscectomy, which is really what they're talking about, involves, number one, bigger incision, number two, cutting your fascia and destroying it, number three, destroying the muscle by peeling it off your spine and cutting it, number four, cutting a hole in the bone in the back of your spine to get to the herniation called a laminotomy, and foraminotomy and partial fascectomy. They're destroying your spine. What more do you need to know? That's the one thing you need to know. And then they can't even get the herniation out completely. They use grabbers to pull what they can. I use a laser and an endoscope to 1/100th of a millimeter remove the herniation. So the difference is Deuk laser disc repair, we don't destroy your spine at all. We don't harm your spine. Microdiscectomy, they destroy your spine by removing bone, ligament, joint, capsule of the joint, synovium. They destroy the muscles in the back of the spine. We don't destroy any muscles. They destroy the fascia holding your spine together. We don't destroy any fascia. Their surgery doesn't work. It works 50-50. Our surgery works 100% of the time. Okay? And their surgery has a high reherniation rate. Our surgery doesn't. Why? Because we're cleaning the tear. Your body heals it. Your body cannot heal after their surgery because the tear still has all that junk in it because they never took it out. I mean, that's just a couple. You're going to be in a lot of pain after microdiscectomy. With Deuk laser disc repair, you're not in pain. Microdiscectomy, you're taking narcotics, opioid, painkillers, Percocet, Lortab, whatever your doctor gives you. We don't use narcotics because you're not in pain because we didn't do any damage internally. There's too many differences to name them all. But microdiscectomy, endoscopic microdiscectomy, fuckolectomy, whatever you want to call it, sodomizectomy, it doesn't matter. The best is the Deuk laser disc repair, by far. There's nothing that comes close. All these other jokers, they're trying to trap you in with the name of their procedure. It's garbage. We broadcast our surgeries for a reason, so you can see the surgery and understand what we're doing. We show you animations, what we're doing, so you can understand how we're not damaging your spine to fix the problem. Those guys hide their surgery from you because of all the mistakes they make and all the damage they do internally. They don't want you to see it because you would be biting their nails so hard your fingers would come off. Anyway, next question.
Next question from Nicholas, once more on Facebook, asking also, can this work? I assume this work for meaning the surgery. Can this work for adhesive capsulitis?
Can this surgery work for adhesive capsulitis? Yes, but it depends on what capsule you're talking about. You're talking about the shoulder capsule, the knee capsule, the hip capsule, the facet capsule. What are you talking about? The disc capsule? So it really depends on what you're talking about. Next, I'm going to get a question. What's the difference between a Deuk laser disc repair and an ICBM?
Yeah. And next question comes from, its name comes from Sexy Eyes.
Sexy Eyes. Yeah. Welcome, Sexy Eyes.
And
I like that name.
They asked, may I ask how much this kind of surgery is? The example of L45 outside this one.
Yeah, the surgery is very inexpensive compared to alternative types of surgery. So more invasive surgery, more expensive. Fusion, even more expensive. Artificial disc, very expensive. This is very inexpensive. I don't have exact numbers, but you're probably talking about a few tens of thousands of dollars. Probably somewhere around 20 grand if I had to guess. Okay, I don't have the numbers. What I get paid is about 10% of that. So I don't make as much as I would make doing a fusion. Fusions are about 10 times more expensive.
And then lastly from Mohammed on YouTube asking, can a single disc could tear from multiple sides?
Yes, a disc can tear from multiple sides, absolutely. What causes the disc to tear is trauma, an accident, some type of force on the disc that tears the annulus, and the facet capsule usually as well. So can you tear the annulus in more than one place? Absolutely. We get what are called broad-based annular tears. And by the way, once you tear it initially with the force, then tearing it more is easy to do. Just kind of like take a pair of jeans, right? Try to pull your jeans and tear it. You can't tear it. It's too hard. But once you get it started with a lot of force, then you put your fingers in there, you can tear the rest of it easy. So once your annulus is torn, tearing it more is easy.
And no current questions, just a comment from Bo on Facebook saying, I'm getting an MRI today. Hopefully we'll be getting with you soon, but I have more to than just the herniation, like narrowing of the foramen.
Yeah. Folks, when we talk about fixing the herniated disc, there's more that's going on other than the herniation. Okay? And I know for most of you out there, you're struggling to understand what's wrong and what needs to be done to fix it all. Deuk Spine Institute is the leader in treating everything related to your spine, except for cancer and except for infections. So, if you don't have cancer in your spine, you don't have an infection in your spine, we are the leaders in the world in treating it. So don't think for one moment that just because you have stenosis or scoliosis or arthropathy or ligamentous hypertrophy, we don't know about it and we don't know how to fix it. We can fix it. You don't need those things fixed. That's the thing. You only need the tear and the herniation fixed. All these doctors have you believing that all these other findings on your MRI are important. I used to believe they were too, but they're not. They don't contribute to your symptoms. So they don't need to be fixed, and they shouldn't be fixed because fixing them is dangerous and unnecessary. The only thing that needs to be fixed is the tear and the herniation. Now, if you have facet pain, you need your facet dealt with. But if you're talking about discogenic pain, this surgery is the minimally invasive, least amount of surgery that can be done to get rid of your problem. All the other surgeries are not treating the source of your pain. They're just treating something else that hopefully, if you're lucky, they'll get your source of pain as well. That's why those surgeons will tell you, if you ask them, are you going to cure my pain? They're going to tell you there's a 50-50 chance you'll get better. 50-50 chance of getting better? I don't want to be better. I want to be fixed. So if you want the best, you come to Deuk Spine Institute. That's really what it comes down to. Stop fucking around with other doctors and other clinics. They're only going to hurt you, like the guy earlier who has a voice box injury because of his ACDF. All right? 50% complication rate with ACDF, anterior cervical discectomy and fusion. For artificial discs, it's about half of that, 25%. But with the Deuk laser disc repair, zero complications with this procedure. Which would you rather be, the one getting complication or not? Be smart about it. Endoscopic Deuk laser disc repair is the best. Thank you, Laura. We'll see you soon.